So good afternoon, everyone. My name is Becky Seabrook, and I'm the Senior Director of Guest Engagement at the Health Museum in Houston, Texas. And I want to welcome those of you who are joining us today to our session of our ongoing series with the Menninger Clinic called Parents Let's Talk Mental Health with Menninger. Today's topic is ADHD, what to know and where to turn. And I am so pleased to welcome Dr. Alton Bozeman as today's guest for the conversation. Dr. Bozeman is an assistant professor in the Menninger Department of Psychiatry and Behavioral Services at the Baylor College of Medicine, where he serves as the director of outpatient assessments. He also provides psychological, developmental, and neuropsychological assessment of children, adolescents, and adults, as well as individual therapy. And he is noted for his expertise in autism assessment and intervention. Dr. Bozeman did his undergrad degree at Texas Christian University in Fort Worth, Texas, and earned his doctorate of psychology from the Chicago School of Professional Psychology. He completed a pre-doctoral internship in pediatric neuropsychology at the University of Miami, Jackson Memorial Hospital, and a postdoctoral fellowship at Canyon Lakes Residential Treatment Center in Lubbock, Texas. Dr. Bozeman, I want to thank you so much for joining us today. In just a moment, I'm going to turn the screen over to you so that you can do your presentation on the topic. And then once that presentation is completed, I will rejoin you and we'll have a conversation on ADHD. For those that are participating this morning, I want to encourage you to use the question function in Zoom to ask any questions that you have for Dr. Bozeman. You can find that by taking your cursor and hovering at the bottom of the screen where it says Q&A. If you'd like, you're welcome to submit the questions anonymously if you feel more comfortable doing so, and we will be recording this session so that we can make it available as a resource for the community. So Dr. Bozeman, thank you again so much for joining us today. You're a very busy person, but this is a really important topic for a lot of families. So at this point, I am going to turn it over to you.
Thank you. Thank you for having me and welcome everyone. So today we're going to talk about ADHD. And so we're going to start off with what is ADHD. So typically given a presentation, this might be a summary, but for this particular disorder, I think the diagnostic criteria is actually kind of telling because it tends to be pretty observational as to what you would see in the environment or what you might be experiencing. So it is a neurodevelopmental disorder, meaning that we believe that you're born with it, or it's at least if there's an environmental aspect to it, it happens very early on in life. And it's marked by a persistent pattern of inattention or hyperactivity, impulsivity that interferes with functioning. And that interfering with functioning is an important aspect that I'll keep mentioning as we go on. So the diagnostic criteria. So we use the DSM-5. It's kind of our manual for diagnosis, and they tend to be pretty broad in general. What the criteria wants to do is allow clinicians to be able to use their clinical judgment. So I'm going to go through the criteria, and then I'm going to kind of explain what that might look like in the real world. So often fails to give close attention to details, makes careless errors. So somebody that's kind of knows the answers maybe on a math test, but makes little careless errors that makes their grades go down. Difficulty sustaining attention to task or play activities. Often seems not to listen when spoken to. So this wouldn't be necessarily intentional, not listening to somebody, but just appearing as though they're not listening, and it's because they're so focused on something else or inattentive. Often does not follow through on instructions and fails to finish tasks. So this is a big one, especially as parents. This is one that's going to cause a lot of frustration for us because of the lack of follow through. Maybe they're forgetting it or they become distracted midway through task. And then often has difficulty organizing tasks and activities. And so this is kind of what we consider executive functioning. So this is our planning and organizing, and it has a lot to do with like time management and just coming up with systems that we use throughout the day to help us stay attuned to things. And so somebody with ADHD usually will not be that strong in those areas. So specifically to inattention continuing often avoids reluctant to start tasks that require sustained mental effort. So we're going to talk about anxious avoidance later on, but for somebody with ADHD, over time, they will start to kind of avoid tasks that they already know is going to be mentally taxing, and so such as homework or studying for tests. Often loses things necessary for tasks or activities. And so this would be misplacing keys, misplacing binders that you need for class, losing your phone. And so this especially should be evident in things that are needed for that day's activities. In other words, things that we should have put a priority on, but we fail to if we have ADHD. Often easily distracted by essential or unrelated stimuli. Any essential or unrelated stimuli. So again, kind of different from anxiety, where maybe we're thinking about bills that are due or something that's bothering us. With ADHD, it's going to be something more unessential. So looking out the window, is what we say, maybe chasing squirrels, right? Thinking about something completely unrelated to the task at hand. And often forgetful in daily activities of functioning. And so that's just, again, that kind of lack of follow through, forgetting what they were supposed to do during the day. Now switching to the hyperactivity and impulsivity. Often fidgets or squirms in seat, and kind of self-explanatory. And one thing I'll also note as we go through is that the criteria tends to be written very much towards children, and can sometimes make it hard for us to identify in adults. And although ADHD can be in adults, it starts in childhood. But oftentimes, if you're first time considering it as an adult, the diagnostic criteria you'll notice tend to be kind of oriented towards children. Often leave seat when remaining seated is expected, such as in the classroom. Often runabouts or climbs. May struggle to play or engage in leisure activity quietly. So a loud talker makes more noise with their toys than necessary and so forth, and more disruptive to the environment. Struggles or uncomfortable with remaining seated for prolonged periods of time. And so, the person's getting up. This one would just be kind of like starts becoming uneasy, starts moving around. And so this one might also be kind of more internal, that internally you're feeling like you don't want to be there. Often talks excessively and speaks out of turn and cuts others off. So this is a big one that shows with impulsivity. So it's kind of a tunnel vision. Someone's talking to you and you're kind of thinking more about what you want to say next, and you're really kind of tuning them out because you so quickly want to say your part. Also, a lot of times these people will answer questions before the question is even complete. And so somebody will cut somebody off and has difficulty with taking turns. And so which goes into the next one, trouble waiting his or her turn for activities, and often interrupts or intrudes on others. And that can also mean personal space. Again, kind of having tunnel vision and invading into one's area of space. So these are the kind of general now that have to be present for it to qualify as ADHD. Okay, and so one thing to keep in mind with this is that ADHD is an etiology. It's a specific etiology, and so it is not just a list of symptoms. So, for example, something like dyslexia, which is the inability to read. And so if you have difficulty with phonics, you can have dyslexia. If you have difficulty with sight reading, which is memorizing a word, when we see cat, we don't spell it out, we just memorize it. So if you have difficulty with that, you have dyslexia. So there's all these different ways you could have dyslexia, because dyslexia is the result, which is difficulty or inability to read. With ADHD, it is not the result. It's a specific etiology that's causing inattention. Lots of things can cause inattention. And so one of the things, with these diagnostic criteria to keep in mind is it has to be evident in childhood. It may not get diagnosed into adulthood, but when you look back retrospectively, we need to be able to see evidence of it in childhood. It needs to be present in multiple settings. If it's only present in school, that would not qualify for ADHD. The individual may really dislike school. It's only present in church, and that's not going to qualify as ADHD. The person might be bored in church. So this is something that we have to be able to see in multiple settings. And then significant interference in functioning. and then not better explained by another disorder. So if somebody has severe autism, so you can have autism and ADHD at the same time, but if somebody has like more severe autism or lower functioning, then that's probably going to account for their inattention. Or as we get into some of the other differential diagnoses like depression and anxiety. And then it has to cause significant interference in functioning. And that's one that people will forget often. So the goal is to address or treat a disorder that leads to actual deficits, actually struggling in an area of life. The goal is not to address a lack of optimal performance or transient condition. So oftentimes we'll get a lot of really high achieving individuals. They put in 60 hours work weeks. They're very organized. They're very driven. They do not avoid tasks. They stay on top of things, but they find themselves really struggling when work gets really pressure filled, or when they go off to medical school and then they'll think they have ADHD. And so I have to explain to them that, hey, this is an actual deficit. This is where if you're in a group of a bunch of individuals in a classroom, you're probably on the lower end when it comes to executive functioning, planning, your time management, and so forth, and not an idea of like, oh, my optimal performance should be this. I don't feel it's there, and therefore I must have ADHD. So other conditions that impact attention or impulsivity. So this would be what we would consider to be rule outs. And the reason why this is important is because you want to make sure that these are being considered for yourself or your child to have ADHD. Also, another thing to keep in mind is ADHD and these disorders are not mutually exclusive. So you can have both. So if you have these and there's also impacting your attention or impulsivity on top of the ADHD, it's still important to address it so that you can reduce the symptoms as much as possible. So trauma is really likely to impact attention, and it also may impact restlessness, especially if you're jumpy or if your trauma regarding certain stimuli in the environment will make you appear to be restless. Depression slows down our processing, and it's very likely to impact our ability to attend to things. Anxiety is likely to impact attention. This is the one that's most likely, just by numbers, to mimic ADHD, especially in childhood anxiety. And it's also likely to impact restlessness because it might be more of an anxious, restless squirming instead of ADHD hyperactivity type squirming or restlessness. Poor sleep. So this could be at the level of true insomnia, or it can just be kind of more transient, poor sleep in the acute phase, and that's also going to likely to impact our attention. In fact, when sleep is really poor, it can look almost like a neurological deficit. It has such a strong impact on our cognitive ability, including our attention. Substance use likely to impact attention, especially if you're on depressants or on stimulants, and then it might impact our restlessness or cause hyperactivity if you're on stimulants. And ironically, the medication for ADHD tends to be stimulant based, and one of the things you do want to look for is if it's increasing restlessness or anxiety. And then marijuana, cannabis is the one that we see most often that's mimicking ADHD. So assessment of ADHD. And so I want to divide it by provider types. Most of our ADHD is first going to be identified in the schools. And so oftentimes that means that the schools are the largest provider of assessments. And so at that level, it might be a school diagnostician. And I'm going to speak from Texas, just kind of know Texas the most. And I think most of our viewers probably from Texas. And so school diagnosticians, and then in Texas is LSSP, Licensed Specialist of School Psychology. Some of our larger districts, such as like Cy-Fair in the north of Houston, tends to have a lot of doctorate level individuals, and so they're school psychologists there. And so in the schools, their assessment is going to usually be very observational based, and what they're looking for is eligibility for services or special education within the school system, and oftentimes they're not going to give a diagnosis if they are licensed independently, like as a psychologist, they may give a diagnosis. Otherwise, they might give just kind of the criteria that your student qualifies for services within the school. And then we have the master's level clinicians, LPCs, licensed professional counselor, LCSW, licensed clinical social worker, and LMFT, licensed marriage and family therapist. And so the master's level tend to be identified by their license. And then then we have psychologists and psychiatrists. And so the doctorate level the letters you'll see tend to be whatever their credentials, their degree are, and not their license. So a psychologist will usually be followed by PhD or PsyD or ED, and then psychiatrist will be MD, a medical doctor, and same with neurologist and pediatrician. Within that, you have developmental neurologists and developmental pediatricians, which specialize in kind of the behavioral aspects of childhood medicine. So moving into assessment types, you have informal assessment. And so informal assessment actually is what probably most people will receive, generally speaking, when they go to a provider. And so informal assessment is kind of just in progress. So you're seeing a therapist, and after a certain number of sessions, the therapist makes a diagnosis. It might be for third-party reimbursement, it might be for treatment planning, but there's not an actual sit-down session that is intended to be an assessment. For ADHD, this is pretty rare. Usually if somebody's doing an informal assessment with ADHD, it's going to be more of, hey, have you looked into this more so than I think you have ADHD, or giving a diagnosis formally. Next levels, we have screeners, and screeners are likely to be seen in the pediatrician's office or in a family practitioner. And so they're based on behavior related questionnaires. And so they're going to ask the parents about certain behaviors that you're seeing in your child and check offs. And so one of the things about screeners is they have a really high sensitivity and low specificity. And what that means is that a screener, you want to capture everybody that might have a condition. You don't want to miss anybody because it's a screener, it's the front door. And so what that means, though, is it's not very specific. And so it means that there's going to be a lot of false positives with screeners. So screeners are not intended to be given alone, but unfortunately that is the case a lot of times, especially like in a pediatrician's office. And so it's something to be aware of, or if you're on the internet and you find a do I have ADHD kind of measure, right? Odds are it's going to be a screener. So it's going to have a high sensitivity, low specificity. So a lot of false positives. It should only be the front door before additional assessment. And so after that, you have interview-based assessments. And so interview-based assessments would be what's likely to occur if you see a psychiatrist or a pediatrician or neurologist that are kind of developmental based and kind of giving a focused assessment of ADHD. And so these would be a long form interview on your developmental history and symptom presentation. Then next step up from that would be testing-based assessments. And so this is what you're most likely to have in the school setting, or if you see a psychologist. And so these are going to be formal tests that are normed, looking specifically for ADHD or maybe other cognitive issues that may look like ADHD. And both the interview-based assessments and the formal psychological assessments should include much more. Their scope should be bigger than ADHD, because you also want to see, are there any disorders that are mimicking ADHD or looking like ADHD? So for example, if somebody was using cannabis often or had insomnia, and you only assessed for symptoms of ADHD, then that individual is going to come up positive. And so you're going to miss, though, what the cause is. Going back to what we said, ADHD is a specific etiology. And so you could end up missing that, and it ends up getting an ADHD diagnosis when in reality, your inattention is being caused by cannabis use or insomnia. And then lastly, and the most involved, is the observation-based assessments. And so these are usually completed in the school to determine education impact. So in the school setting, they're going to give both the interview-based assessments, they're going to give the testing that we mentioned, and then they're going to give observation. So oftentimes a diagnostician or somebody is going to be in the classroom looking at your child and seeing if the behavior actually manifests in actual functioning, because that's a needed component of ADHD. So in some ways, the school-based assessment is the most ideal and the most gold standard. However, the focus and intent of it is a little bit different than in a clinical setting. So diagnostic overshadowing. So diagnostic overshadowing is when a condition has we're so aware of the condition that we tend to miss other conditions or attribute all behaviors to that condition. So we have a child who's extremely disruptive, extremely dysregulated, maybe aggressive, getting into maybe a teenager using drugs, and everything is attributed to the ADHD. And so I wanted to have this slide in here to remind people that, hey, not every unwanted or maladaptive behavior is attributable to ADHD, even when somebody does have it. So for example, ADHD is not purposeful oppositional behavior. And so an example of that would be, let's say you have a 10-year-old who's throwing a ball in the house and you have breakable items in the home, and you tell your 10-year-old, hey, stop throwing the ball in the house. If a 10-year-old looks you dead in the eye and throws the ball again, that's not ADHD, right? That's a purposeful oppositional behavior. That's more of a conduct disorder. Doesn't mean that they don't have ADHD, but that particular type of behavior is not ADHD. Now, if you have a 10-year-old who's throwing a ball in the house and there's breakable items and you say, hey, don't throw the ball, they look at you and go, oh, sorry, like they've caught themselves. And then 5 minutes later, they throw the ball. That might be ADHD, right? Because now that's that impulsive behavior coming out. That's that quickly they forgot the instruction you gave them, or they saw the ball, tunnel vision through the ball, and then they're like, oh man, I wasn't supposed to throw the ball again. And so that's different. Same with like running around in the classroom and you tell them that, hey, stop. And then they stop themselves, but maybe 20 minutes later, they're back to being overly excitable and running around the classroom again. That might be ADHD. You tell that child to stop and they look at you and don't care and keep going about it, then that's kind of, again, more that purposeful oppositional or conduct behavior. Anxiety alone is not ADHD. So anxious avoidance. Now this one can be tough because over time, somebody with ADHD will start to have anxiety about the consequences that their ADHD has caused. But there's also just anxious avoidance, which is just, I really don't want to call this person because I know that they're going to be upset with me. And so they avoid the task. I really don't want to look at this bill because I know it's going to be more money than I have. And so they avoid the task and their bills don't get paid. And so that can look kind of like ADHD because things are still not getting done. There's still a lack of follow through, but it's more anxiety driven. Extreme mood dysregulation. So this is a big one recently with the onset of social media and more people talking about things like ADHD and autism and social media. What I see now a lot is a lot of people with extreme mood dysregulation. Somebody completely flies off the handle, or somebody that has exaggerated reactions to things and attributing it to ADHD when that's kind of might be more personality driven or more driven by an acute onset things such as like depression. And so one way to think about this with somebody with ADHD is that, so with ADHD, somebody might have an emotional reaction that we seem to be inappropriate, but it's usually kind of more impulsive driven. So for example, if somebody's walking around, they're being very careless and they bump into us. And they're not very apologetic when they bump into us, and they bump into us with some force and it causes us to get hurt. So all of us might be very annoyed with that. And so somebody with ADHD might be annoyed by it and then say something and blurt out something kind of mean and kind of rude or show that anger. Okay. And so while we wouldn't have had that reaction and the person with ADHD did have the reaction, we're able to see where that reaction came from. They're like, hey, you know what? I would have been upset if that happened to me also. But what happens with the person with ADHD is that impulsivity makes them verbalize it maybe or react in a certain way. Versus extreme mood dysregulation would be someone really gets upset because someone says something to them and everybody else around is like, I don't know why you're so upset, or I don't think they meant it that way, or why did you take that as a challenge? Why did that make you feel this way? So if you kind of can't see where it's coming from, then that's kind of more, personality based, or again, maybe related to something else like a depression and that irritability. Poor judgment versus impulsivity is another big one that now I see get a lot of attention and misdiagnosed as kind of like an ADHD related impulsivity. So again, like those examples we talked about, I pick up the ball, I see the ball, I throw the ball, right? And that would be impulsivity. I blurt out something before it's my turn, right? Again, related to impulsivity versus poor judgment. So we've had examples of people that will say, hey, I really needed money. I sold my car to get money, and then later I'm stuck with no car. All right. And then they'll say, oh, that was my impulsivity. And it's like, well, no, while we may consider that an impulsive behavior because you didn't think through the consequences of not having a car, you still had to list your car. You had to find a buyer for your car. There were many steps to that. That's not the kind of impulsivity we're talking about with ADHD, which is kind of more bang, bang type of impulsivity instead of like a series of bad decisions or judgment. So moving into treatment strategies, medication for ADHD is still the most efficacious way of addressing ADHD. Most of the medications are stimulants. There are some medications such as Strattera, that's norepinephrine, it brings more norepinephrine. And then there's currently like guanfacine and Tunif, which are kind of blood pressure medications. And so they're kind of more for calming an individual. But the primary medication used is going to be stimulant medications, which theoretically increases dopamine in the frontal lobes, that same area that allows us to inhibit our responses. And so therefore, pay more attention. And if we're paying more attention to things, then we also appear more calm. And then psychotherapy. Psychotherapy is very important for the secondary consequences of ADHD. If somebody has ADHD, and we talked about the differential diagnosis between ADHD and anxiety, but eventually it often leads to anxiety. So when I get old enough to actually care about my grades or care about what people think of me, then I'm going to start to have anxiety that my grades are lower than what I would like, that my parents are going to be upset, and I have anxiety that my boss is going to notice that I didn't turn in my work in time. And so it will start to cause an anxiety, and soon they'll be there together. And so psychotherapy is an important part of addressing the secondary. There's higher substance use with people with ADHD. Again, it might be due to the coping related to the consequences of ADHD. It might be the kind of need for more thrill seeking or a need to be about. And so the substance might bring that to them. Poor self-esteem. So individuals with ADHD eventually might start to label themselves as not being as smart or as capable as other individuals. And so it'll start to impact self-esteem. And then family tension. So we talked about what ADHD is not. ADHD is not lying. However, lying is very common in people with ADHD, especially children, because they start to want to avoid that consequence. Did you do your homework? Yes, I did my homework. Why did you get that 0? The teacher just hasn't put it in the grade book yet. And also, like we talked about with ADHD, that avoidance of tasks that are going to be mentally taxing. And so that might also lead to lying from our kids or teenagers who don't want to do that particular task and tell you that it doesn't exist. So treatment strategies that you could do at home and also with the use of a therapist will still be beneficial. It's behavioral interventions. So the best results for somebody with ADHD is a combination of behavioral interventions and the medication. So when used alone, the medication is the best, but ideally you want to use a conjunction of both behavior and medication. So a good example of something you can do in the home is contingency plans or token economies. So this would be something where you set up maybe a chart, and so you reward your child for getting all their homework done during the course of a week, completing all the tasks that you gave them during the course of a week. And so the tokens can equal something of value. It can equal screen time for playing games. It can equal a trip to ice cream to get a dessert, various things depending on your child and what's reinforcing to your child. And so I have a picture of poker chips, which is actually what we used in my house with my children. And so you can have it where black poker chips equal, 30 minutes of playing time, blue poker chips equals 10 minutes of playing time, and so on and so forth. And the children, when they're younger, enjoy trading out the lesser valued poker chips for the bigger value poker chips and so forth like that. And so what you want to do is you just want to focus on only a few behaviors that the ADHD is causing problems areas. You don't want to look at too many because what will happen if you look at too many is the kids will end up focusing on their strengths, and then they'll still avoid the behaviors that are most problematic. So you want to think about what are the 2 to 4 most problematic behaviors in the house that we either want to increase, like compliance, cleaning rooms, doing homework, or that we want to decrease, such as lying or getting zeros on assignments. And then the other forms, treatment strategies, is compensatory strategies. And so compensatory strategies don't actually fix ADHD, but what they do is there are strategies that you can use to help with somebody with ADHD. And so they're going to primarily target executive function, like we're talking about the planning and organizational aspects, the deficits. So using a calendar, using a programmer in school. So anything that's going to remind you, using alerts on your phones with the apps and things like that. And so they will always have to be utilized, because there's no such thing as I use the planner so often that my ADHD went away. You're going to always have to use the planner. Or if you use strategies of always using white space, lots of white space on the paper when I write things so I don't miss details, right? You're always going to have to do that. You're not going to get better at being able to see details over time. So the difficulty part of this, of using compensatory strategies, is it requires even more executive functioning. So use a planner requires executive functioning. And so the difficult with this is that you're going to probably have to really stay on top of the person. So my kid's school district is actually really good in that they give the kids bonus points for using their planners, and they want to see evidence that they're using their planners. And so that's a good strategy. Okay, so this slide is, I just wanted to really stress the importance of process. With somebody with ADHD, reward the process, and not the results. And this is really hard because we tend to be a results-driven society. But so people with ADHD, for one, a lot of times, if they're bright children, they don't want to mess up that image that they're bright, and they will start to avoid activities that might show in their eyes that they're not bright. We know that it's not really about that. We know that it's really about their inability to focus or to get things done in poor time management. But for them, if they're seeing poor and failing grades, they might start to doubt themselves and start to internalize it. And so what's really important is praising the process. And so what this means is, how does one make a better grade? They study more. They do their homework, they get their assignments turned in. And this is the aspect that you want to praise. You don't want to praise that they got the A on the report card. And so, for example, if you have a child who really struggles in math, which is the subject that most likely to struggle with ADHD due to its need for stepwise progression and detail, and so really struggles in math, and they're failing math throughout the whole grading period, and they have all the rest of their grades for A's. Okay, when that report card comes out and they have a C in math when they've been failing it the whole time, that's the grade that needs to get the most attention. However, we're not going to wait until that grade comes out to give the attention. What we're going to do is we're going to reward and praise verbally, through tokens, through whatever. Hey, you got all your homework in on math. Hey, I saw that there were no zeros in your math. Hey, you studied for that math test, and this is going to get praised and praised and praised, the process. And so then in the end, when they get that C, now we're only pointing out that that C is the result of their hard work. And maybe they get higher than a C. I'm just using a C because I really want to stress how important it is that even though that's two steps below an A, that's the grade where you got to see the process, and that's what you're going to reward. And that's something that's going to be important for the rest of life, because it's always how you got to that end and not so much the end. So ADHD in the school system. So educational need versus diagnosis. Like I said, some schools will have independently licensed psychologists, and they will give diagnosis. Usually in a school setting, what they're looking for is educational need, the determination. And so going back to those differential diagnoses, let's say we have somebody who observationally looks like they have ADHD, but they also have, we know, severe insomnia, or they're drinking alcohol. In the school system, it may not matter because they're not going to see that. They're not necessarily assessing for that. And so therefore, educational need, they end up qualifying for the ADHD. And so it's not, the differential diagnosis is not so important, because in the end, they are still struggling with these areas in the school, and it's the school's job to address it. Versus clinical diagnosis, where we're going to rule out or attempt to rule out all those differential diagnoses that might be mimicking ADHD. And so we're going to give a diagnosis. So in the school settings, you have two different sets of accommodation levels. You have 504 and you have special education. So 504 is actually the section within the Rehabilitation Act of 1973. And so that's the specific section that deals with addressing the needs of children in the school setting. To make sure that they're not discriminated against. And so the criteria for having 504 accommodations is pretty simple. It's going to be straightforward. They're going to get testing and meet the criteria, while special education is its own law, and that's the Individuals with Disabilities Act, and that's a much harder bar to reach. And usually somebody with ADHD is not going to qualify for special education unless there's other disorders or emotional functioning that's going along with it. But special education is when the curriculum is actually changed. So 504 would be accommodations. So extra time, right, would be an accommodation. Special education would be a changing of the curriculum, right? Either reducing the curriculum or changing it in some way, modifying it to meet the needs of the child. So some common accommodations for ADHD, extra time is going to be the most common one, time and a half. There might be extra time to also finish assignments that go home with the individual. Preferred seating is one that you might see often, or even being able to take a test in an area where there's more quiet would be another example of accommodations. Extra white space. So again, like a math test where there's a lot of text on a page, and so the child then is going to also be showing their work. And so in the combination of that, details get lost and end up missing the math problem. So somebody with ADHD, we might ask for there to be more white space so that they don't lose those types of details. Preferred seating in the classroom, having a child sit away from their friends, having them sit away from windows or other areas that might be distractions. And so oftentimes if you have psychologists or psychiatrists write some of the accommodations or recommendations, and so oftentimes the school will take that to heart. And depending on the school district, the school's also going to have a lot of their own ideas. And so my experience working with a lot of school districts is that they already have a pretty thorough bank of accommodations, but sometimes there can be some uphill challenges with that. So also a word on testing and identification of the need is that by law, the school district has to test. And because we all pay taxes to a particular district, even if you do not attend that school, you could still get services through that school district due to the fact that you're a taxpayer within that school district. And so from the time that you make a request, the school has a certain amount of time to address your concerns and to assess your child. You could also go, like we mentioned, to a psychiatrist and developmental pediatrician or neurologist or psychologist, get the diagnosis that way, and then take it to the school and see if they will recognize it in some form or fashion to receive your 504 accommodations. So that is the wrap up of presentation. And this is a very, very broad topic. And it's something where almost on any one of these slides alone, I could talk for 45 minutes. So let me know your questions, but I also want to put my contact information here so that if anybody has follow-up questions or concerns, you can also reach me directly.
Great. Thank you so much, Dr. Bozeman. We do have a couple of questions coming in. A reminder to those that have joined us that there is a Q&A button at the bottom of your Zoom screen, and you can submit your question there. To start off with the questions, how much do we know about the biological basis of ADHD?
So we don't have biological certainty, but we do know a lot about ADHD. So, and a lot of times it's on what we consider the research level, as opposed to the diagnostic level. So for example, on the research level, if we look at a lot of frontal lobes, let's say if we gave a structural image of 100 children with ADHD and 100 children without, that overall that there might be smaller frontal lobes of the children with ADHD. We know that dopamine in the frontal lobes helps with attending. And so even things like coffee help us attend. And so the medications increase the dopamine in that part of the brain. And the medications, like we said, are efficient and effective. So that's what we believe to be the primary primary mechanism.
Okay. One of the questions that's come in is, how do you discern between normal childhood inattention or energy and something like ADHD?
So it's a really good question. And so really it's kind of just doing that, right? Which is thinking about what would be the behavior of this individual developmentally. I gave the examples about throwing the ball, of ADHD versus oppositional. Chose a 10-year-old on purpose because if you took that and reduced it down to a 4-year-old, a 4-year-old with ADHD might look you dead in the eye and throw the ball anyway. That might still be ADHD because they don't fully maybe respect or value the idea that something can break. They don't fully get why you're giving this direction, why you're so serious, if you're even serious. And same with like the running around in classroom example, right? Why do you need me to stop running around? And so therefore that lack of appreciation might make them have a more oppositional appearance than the reality. It might still really just be ADHD in that case. So yeah, we definitely always have to consider developmental aspects of where you're at in your age, or if there's other conditions that influence development, such as autism or intellectual disability.
And is there a typical age where you really start seeing that diagnosis kind of come into play, like an age at which it starts becoming clearer that there is a difference, that there is something going on beyond what's typical?
No, not necessarily, because again, if you're going to somebody who is formally trained in this kind of assessment, that should be a piece. So even though a 2-year-old or 3-year-old might have less developmental awareness, then that should still be part of the assessment. Those, how are they acting relative to other 3-year-olds? And so that's part of the assessment. Of course, as somebody gets a little bit older, it might be even easier or more apparent because they might at that age start having some of those failures we're talking about, like in school or assignments or follow through, that you don't have such expectations on 3 or 4-year-olds.
Right. I've heard in kind of informal conversations with a lot of parents that oftentimes when they really start seeing trouble in the classroom is when they start thinking about the need for assessment. Do you have any advice for students that are kind of having to have that conversation with the classroom teacher, either kind of pre-assessment or even post-assessment, to sort of get both the parents and the teacher on the same page and kind of helping to support a child who may have ADHD in the classroom?
Yeah, so first I would say, so when a teacher makes remarks, and sometimes, just the reality is that it might first come across as complaints. It may not always be constructive. It might be, hey, your child is being disruptive. So you keep track of that, document it. Because when you get a few at that point, it's become an educational need. And so what the law is, the school must address educational need, right? And so if your child's being disruptive in the classroom, that's not your house, that's the classroom. And that's not your issue at that point. That is the teacher's issue, right? And that's the school's issue. So at that point, it's an educational need. And any emails saying that is documenting that it's an educational need. So that helps with getting the request for testing. I want my child to be assessed for ADHD because you all are showing a pattern of an educational need. And that could be the same with constantly missed assignments and things like that. And so working in conjunction with the teacher would be, so after you have an IEP, individual education plan meeting, or an ARD meeting, and so they have the accommodations. The part that's going to be important with working with the teacher is making sure that you're on the same page of what these accommodations mean, and also helping find out which accommodations are most useful. When you go to an ARD, like I was saying, some schools will say, hey, here's a list of accommodations. It's going to be a lot. And then when you're meeting with the teacher, your teacher's like, hey, you know what? Your kid is great with that. That's not needed. And you don't want to have unnecessary accommodations. You want to have as few as possible because you still want to push your child, and you still want your child to be at the top of their potential. And so that's where the working in collaboration with the teacher is going to be really important.
Okay. We have a couple of questions about assessment and also medications. So if a parent wanted to have a child assessed, say at the Menninger Clinic, about how long does it take between putting in a request and actually having an assessment done?
So here at Menninger, we don't do a lot of individual ADHD assessments. We have more specialized assessments that are kind of more intensive and they look at a broad thing. And so, for example, my program, the assessment length is a week, and that's too much for something like ADHD. Now, if somebody has ADHD and other issues, then the assessments we do here at Menninger would be appropriate. But typically, if we did see somebody, we from the time we'd come in, we'd probably get one in within a month, and then the report within a couple of weeks after that. In the private sector, it's going to depend a lot on where you're at, what cities and so forth, but wait times of 3 months is not completely unusual, especially like what you mentioned at the beginning in September and October when school starts back.
Right.
And parents start getting reminded, the wait times for testing, unfortunately, can be pretty long.
Right. Here's a question about when medication kind of comes into play. It says, what level of assessment do you recommend before medication is considered?
So that's going to be, a discussion with your provider. But I like to recommend that the individual has had a full assessment, some sort of testing, something that goes beyond the screeners, or a thorough interview with a psychiatrist, and so a level beyond that of a pediatrician. Now, with that said, there are some pediatricians that are very specialized and focus on ADHD, but again, you're going to be able to tell that because again, it's going to probably be one of those long interview process. So it needs to be either a full, what we consider psychiatric evaluation, interview based, or psychological testing and interview combination. You don't want it to be at the screening level, or if the school did the full observation and psychological testing assessment.
Okay. A couple of other questions about medications and over-the-counter supplements. One, do over-the-counter supplements like omega-3 fatty acids help, and what role might diet play?
So I wouldn't know about that over-the-counter supplements. I don't want to speak to that. It's something I can definitely look up. The role of diets, definitely if there's foods that tend to make your child hyperactive, or if there's foods that tend to interrupt with sleep, sugar, foods that are with chocolate, and things like that might interfere with sleep, caffeine can definitely end up mimicking ADHD. I would tend to think that diet is more likely to impact the conditions that we say mimic ADHD than it would ADHD directly.
Mhm. And does the challenges with sleep often go hand in hand with ADHD?
They do not go hand in hand. It's something
Okay.
that you would want to be a differential diagnosis: is sleep impacting ADHD? Yeah,
Okay.
where it can loosely impact it would be like what we consider like a behavioral insomnia, like so sneaking your phone into the bed and playing games all night, or being on the internet, that would definitely impact.
Okay. Do non-stimulant drugs like Quellberry, I think that's what it's called, help with pediatric ADHD?
I would have to look into that one specifically. Strattera has been around, and then that one is a new one, and Tunif and guanfacine. They all have some level of efficacy for them to get approved. This might be a question specifically for a psychiatrist to be able to answer a little bit better.
Mhm.
But overall, the stimulant medications have shown, and the research I looked at, the stimulant medications just didn't have a better effect than Strattera. But again, kind of like what we're talking about on the research level of something where you look at 100 and you can see this difference or a pattern, but you look at one and you cannot, that would be where I would be cautious in that. In other words, Strattera for one child might be a much better benefit than a stimulant medication, for example.
What happens when SSRI type drugs are given to treat just anxiety and miss ADHD?
So if you're seeing a provider, especially a psychiatrist that has prescribed SSRI for your anxiety, then we want to believe that that's the best treatment for that. And so I don't want to speak or second guess on anything like that. But if the ADHD is missed, then some of the symptoms that are attributable to the ADHD you would expect to continue on. is there going to be any exasperation or making the ADHD worse by treating anxiety while ADHD is missed? There shouldn't be. It's just that if something is more more ADHD driven and not anxiety driven, then you're not going to get the expected result.
Right. Okay, here's a question. Well, you had talked a bit about the pediatricians and just a moment ago. Is a pediatrician a good place to get a diagnosis for an ADHD or to direct you to someone that can do the assessment?
So with the second part, definitely as a gatekeeper, they are going to most likely be the gatekeepers, usually going to be the school or your pediatrician. That's the first part. It really depends. Speaking from personal experience, my children have a pediatrician whose expertise is ADHD and has a big focus on it. But other pediatricians might be more likely to just use screeners or go by reports, the parent report, and then miss some of the other mental health diagnoses that could be looking like ADHD just because that's not their background. So that part I would say depends, but overall as a gatekeeper, it's definitely usually a good place to start.
Okay. We have a question here from a parent who has a 16-year-old who's gone through the Menninger assessment and was diagnosed with ADHD, but is having trouble. It's a sort of a taller, stronger, 6'2", 300-pound child, and kind of just really trying to navigate how do you handle that when the child doesn't want to gets aggressive. What resources are out there for parents that are trying to navigate that with some of the older children?
Man, it's a tough situation and hard to answer because when we were getting into that diagnostic overshadowing, that would not be the ADHD aspect, right? So that individual adolescent may have ADHD, but there's something too that's leading to aggression, right? And if they're willfully pushing back and being aggressive at your attempts to kind of address maybe some of the things that they're lacking due to ADHD, that aspect's not ADHD, and that aspect needs to also be addressed. And so my recommendation would be working with your provider on finding other resources or direct interventions for what's causing that other behavior.
Okay. Just today in the Chronicle, I saw an article about an Adderall shortage, and I don't bring it up so much because of the Adderall, but because one of the quotations in the article was talking about a rise in diagnoses of ADHD during the pandemic. And I was curious, have you seen an increase in people coming in for ADHD because of all of the changes during the pandemic, or even people that do have ADHD having more trouble navigating, or if there's any benefit with some of the changes we've seen?
Right. Definitely have seen an increase in people asking about ADHD over the last few years. Some of that might be the pandemic. A big part of it, like I said, I believe is social media. It's kind of there's a lot of people on social media attributing a lot of things to ADHD that aren't. And then also on the positive side, that sometimes it is that someone hadn't thought about ADHD until they saw it on social media. With the pandemic, I would imagine that it would be both false positives and actual ADHD. I would imagine that the lack of structure would definitely increase maybe some of the negative aspects of having ADHD. And on the other side, I could imagine with the pandemic and isolation leading to more depression, substance use, and some of the other aspects that we know. And then that again, mimicking ADHD.
I know one of the things that parents are often trying to navigate is screen time. And I was kind of curious, when you're talking about screen time and children with ADHD, are there sort of any kind of extra things to keep in mind, either the benefits of screen or the negative side of it that make it harder for those that have it?
Yeah, so I have to be careful not having kind of a old man perspective on this. Yeah, and we know that from research that the increased screen time is changing our brains and how we think, but we don't necessarily know if that's negative. And so it's tough to answer. What we do know is that too much of anything is negative, and that screens have a very unique ability to pull us in for it to be too much. And so when something is getting in the way of responsibilities, then it's too much. At that point, we would consider, an abuse of that activity. And so screen times, apps, games are purposefully built to have different rewards in them that keep us coming back, right? Facebook, we get likes, alerts, we get dings, right? We get all these things, and there's all increased dopamine, which we keep mentioning with ADHD. And so they bring us back purposefully so that we sell more advertising. And so therefore they're likely to lead to abusive use. So the main thing to think about is it getting in the way of homework? Is it getting in the way of chores at the home? Is it getting in the way of family time? But also other things that should be fun. Is it getting in the way of social activities? Is my child going and playing with their friends less? Are they going out to the movies less? Are they other things that we know are emotionally good for us, right? And so replacing that all at screen time is not good. So that would be the main barometer. After that, you kind of set that. So let's say if you say you've looked at that and you say, hey, you know what, 4 hours during the week is the most I want. So if you set a token economy to where they can earn screen time, you want to set it where the maximum they can get is about 5 hours, allowing for some error. And so if they have a really great week, it falls right at about that 4 hours, right? And if they don't have a good week, then it falls at 2 hours, and it's motivation for them to work harder.
Okay. Dr. Bozeman, thank you so much for coming on and doing this program with us today. We do have 1 or 2 participants that are hoping to follow up with you, and your email is on the screen. We encourage those that have questions to follow up. So Dr. Bozeman, again, thank you so much. Thank you all for joining us today for your great questions, and I hope you have a great rest of the week.